It's always a good exercise both for the presenter as well as the faculty and students to look at various trials and guidelines which are recently published. And at least you should know what is the important message out of it. So it's not humanly possible to know all the details and
A small difference, please don't use flash when you take the pictures because it disturbs the people.
the AHA guidelines, there are three important ones. This is all beyond January 2022. So those before that should be read by you. So it's all about heart failure and aortic diseases and chronic coronary artery disease. So there are important three guidelines. All of you should read in detail. And besides guidelines, I also advise to look at various scientific statements which are released from time to time. They come in circulation and JACC. And most appealing in the last year is heart failure with regurgitation fraction. So it's very important topic, upcoming topic, everyone should know. So what is new in the heart failure guidelines, AHA guidelines? The important four newer things. That is, everyone knows now, four pillar concept of foundational therapies. That is, beta blockers, SGLT2 inhibitors, MRAs, and ACE inhibitors. Then the second is upfront use of ARNI. So there is no need for any pre-treatment, which was followed some time back. And SGLT2 inhibitors have been elevated in their position, not only for heart failure with reduced ejection fraction, but also in mid-range and preserved ejection fraction. And phenotype, tailoring, and treatment of comorbidities are equally important besides the four foundational therapies. With respect to aortic diseases, the surgeons have a lower threshold. They can do the surgery when the aortic size is as less as 5. They don't have to wait up to 5.5. Besides the absolute size, it's important to look at the growth every year. So if the growth is even 0.3 in 2 subsequent years, or if it is an inherited syndrome, then even 0.3 per year is important indication for surgery. Then should always try to spare the aortic wall. And in type B, endovascular procedures may have some growth. And the first degree relation should have imaging screening. These are the things which are pointed out in these guidelines. And ESC is more active. Every year, 5 to 6 important topics, they release the guidelines. And again, heart failure has been the focus besides endocarditis. So, just now in the first phase we talked about endocarditis. All of you better read about endocarditis. So it's very important both for theory as well as viva. Then heart failure with preserved ejection fraction. The statement is quite big one in bulk, but this particular figure appealed very much. One is maybe in the initial stages we have got left atrial hypertension which is exercise induced. Later it becomes even at rest left atrial hypertension is there. Then of course frank right heart failure. You look at the figure how at various stages initially it's all relaxation abnormalities of the left ventricle. Then next is abnormalities of the LA compliance. Then comes the after effects on the right ventricle. So if you remember this phenotyping and the stages, probably you will understand how important it is to pick up early and prevent the progression. And about the treatment, it is SGLT2 inhibitors after diabetes. So ARNI is still not class 1, it is class 2 recommendation. And it's also important to treat the comorbidities and rule out CAD in all the cases of heart failure with preserved ejection fraction. So if you look at the various clinical trials, even group wise, there are more than 100. So I don't think I am expected to talk about each of it, but I have picked up a few which are quite important. The red ones are for me and the black ones are homework for you. Okay. So with respect to acute coronary syndromes, BioVac trial is presented in ACC 2023. It's between immediate revascularization versus staged complete revascularization when the patient presents with ACS. So we already have two important previous trials. One is culprit trial and complete trial. Any volunteer who can tell about the culprit trial and complete trial? Yeah. What was the message?
Sir, in STEMI, in the absence of shock, it is.
We are talking about culprit trial.
Yes, sir. In the STEMI, in the absence of shock, it's reasonable to go ahead with complete revascularization during the primary procedure. In the presence of shock, it is class 3 to go ahead with complete revascularization.
Yeah, so that means that the first trial which has asked us to do all the non-culprit vessels also, lesions also, if there is no shock. So complete trial which is 4 years later it was published, it actually it's a bigger trial and conveyed the similar message. This particular BioVac trial also has found that between immediate and staged complete revascularization, if you are staging, it has got slightly less benefit. That's the message. So try to do everything in first immediate staging may be a little less useful than doing it all at once. Then FIRE trial, this is about elderly people beyond 75 years. This is a large study where the same complete revascularization, whether it holds good even for the elderly. This has proven that it is very useful to do it irrespective of the age. So we should all try for complete revascularization at the first opportunity itself. Then STREAM trial, this is again for the elderly. Those who are unable to reach PCI capable hospital within 1 hour. It's a reasonable alternative strategy is to give half dose of tenecteplase and then bring them and do the revascularization if necessary. So this is again a positive suggestive trial. Then most of the trials have concentrated on FFR and imaging. So there were days when we were trained, just angiography and eyeballing was the ultimate thing. But now any good interventionist should be able to prove his benefit of look at the imaging method of objectively proving whether he has got the correct. There are two imaging methods, as you know, FFR and IVUS, and of course IVUS and OCT are together talked about. So for FFR, everyone knows it's 0.8 or more or less. That's the cutoff for FFR. In IVUS, there are two parameters. One is called MLA, that is stenosis lumen area, and there is block body. I think you have some concept about it. This is the MLA, the red one. This is the atheroma. This by the whole area, as a percentage is the block body. So in this particular trial, they have taken these cutoffs and have proven that FFR guided PCI is non-inferior to IVUS guided PCI. FAME3, anyone knows what is FAME3? It was published 2019. Any volunteer? Okay.
Yeah, please go.
So phase 3 trial was used in FFR in multi-vessel disease to decide whether to do PCA or CAPG. And in FFR, they showed that it was non-inferior, not
No, it did
non-inferior.
not prove to be non-inferior. That is the message. PCI guided by FFR could not prove itself to be non-inferior to CAPG. That is the message. But this particular 3-year follow-up has proven that there is no difference in the events in both the arms. That means what original FAME has shown has become faded out. Difference has faded out. That is the important message. Then renovate complex, again by using imaging guided PCI, the target vessel failure has come down and target vessel related MI has also come down significantly. Then there are 4 imaging guided PCIs which were discussed in ESA, which is last month it was discussed. Just look at the names: Illumin 4, October, Optivus, and there is a meta-analysis comparison of OCT, IVUS and angiography. So Illumin 4 has is a 2-year follow-up of 2000 odd procedures. There MSA after PCI was better if you are using OCT. That means you are getting a better diameter ultimately at the end of 2 years, and the stent thrombosis is lesser. So OCT is definitely better. In October trial also it's again 2 years follow-up of OCT versus angio. The MACE rate is lesser in OCT guided PCI and procedure complications are equivalent. This is particularly only bifurcation lesions they have studied. In Optivus, it's again a comparison between OCT and IVUS and they are equivalent actually. So taking everything together, about 20 RCTs were analyzed, and this was presented and discussed by Greg Stone, and he concluded that compared to angiography guided, image guided PCI reduces target vessel failure by 31%. So it's a significant decrease in the procedural issues, and also image guided PCI reduces stent thrombosis by 52%. That means we should, if we have access for imaging, that is good, and it should be a part of our complex PCIs, at least we should use imaging. And a lot of trials are there using DAPT versus standard. How to reduce DAPT duration, the intensity, that has been the subject of several trials. Anyone knows about Stop Dog 2, which was published here 2 years back? It's a famous trial. See, initially we were giving DAPT for 3 months in bare metal stents and for 6 months in DES, then going to monotherapy. But DAP2 for the first time tried to reduce the DAPT to 1 month followed by monotherapy. But in this particular recent trial, they wanted to have totally aspirin-free strategy from the beginning itself. And they had 2 arms. One is aspirin-free. So instead of aspirin, they gave only Prasugrel 3.75 versus standard DAPT and compared. But by that, they didn't achieve anything. That means Prasugrel alone has caused more events, and the conclusion is that you cannot avoid DAPT at least in the first 1 month. Though you use the most modern type of DES, you cannot avoid DAPT in the first 1 month. So, as a balance between the ischemic risk and bleeding risk, a targeted or tailored risk stratification has to be done. There are several scores which are available to find out whether it is high risk group or high bleeding risk. Accordingly, we have to think of whether we should do prolonged DAPT or shortened DAPT, or prolonged monotherapy or short monotherapy, whether we should cut short the DAPT. All these are decided by a balanced view between bleeding risk and ischemic. That is the message from this particular article after this. With respect to chronic CAD, Marifox study, anyone knows about this? This is an Indian study. Okay. Then there is 10-year follow-up of BEST trial, and FDA has recently approved colchicine as a secondary prevention agent. So these are the 3 important things in the chronic CAD. Rest of them, I think, it's again I told it's a homework for you. Marifax is an Indian study done by Dr. Haigree Rao and another 15 centers in India. We have taken conventional risk factors, 4 of them, diabetes, hypertension, LDL and smoking. Then metabolic risk factors, HDL, BMI, waist ratio and triglycerides and HbA1c. What they found is there is nothing to question the importance of conventional risk factors, but they suggested waist hip ratio and HbA1c have to be added as important risk factors. And they didn't find any value for triglycerides. It's a questionable factor. So this is an important Indian study. This may be asked if Ayurveda comes as example. Okay. Best trial, what was the inclusion criteria for best trial? This is a very famous trial 10 years back. Anybody? It's again left main with triple vessel disease between PCA and CABG comparison. The outcomes, primary outcomes at 2 years, again PCA was not proven to be superior to CABG. Again, the superiority of CABG continued on 4 years follow-up also, but this particular analysis at 10 years, the difference has faded out. So at end of 10 years, there is no much difference between the PCA group and CABG. And with respect to dyslipidemia, I think everyone knows about the first one, clear outcome trials, because the molecule is there in the market now. Then oral PCSK inhibitor has come, is going to be, it is also tested and there is a trial on that. Then Orion trials and reduce it. Can any student tell about one line about all the 4? Very common trials.
Line 3 and reduce it difference. Anybody?
Reduce it is for omega-3 fatty acid.
Which one? Reduce it.
Reduce it. Omega-3 fatty acid.
Was it positive trial or negative?
Negative.
Anyway. Okay, I think there is not much time to. Clear outcome trial, everyone must have heard about it. Bempedoic acid. Okay. This has come after the initial trials like clear wisdom trial and clear harmony trials were published. Based on this has come and the subset tested was ASCVD with statin intolerance. So they have taken statin intolerance patients and randomized, and the primary outcomes were better as compared to placebo. And it may be a viable option. It's already in the market. They are promoting very widely. Anyone knows about its side effects and dose?
Hello. Sir, dose is 90 milligram HS, sir, and side effect is 180 HS, and side effect is hypercalcemia and hyperuricemia and gout was also found.
Gout increased polylithiasis.
Yes, polylithiasis.
Then, yeah, one more question to audience. Can anyone tell all the important PCSK9 inhibitor trials? 4 or 5 are there. Starting from 4 years back.
PCSK9. ODC. Then? Any more?
Okay. So, unless what is the how in what form it is given? Subcutaneous. What frequency?
1 person can answer.
How frequent it is? Okay. Compared to parenteral therapy, oral is always better because the patient accepts it better. So one molecule is coming up, has been tested. Orion trial is inclisiran. Can anyone tell what the difference between inclisiran and PCSK9 inhibitors action? I think you are banned from answering.
Short, small inhibiting organs.
Okay. See, for NDL receptor, it's degraded in presence of PCSK9. It is internalized, and so either you stop the action of PCSK9 by inhibiting it, or stop the production itself. So inclisiran is something which stops the production. So the chart can show you that. So inclisiran is actually given every 6 months, subcutaneous injection, something like a vaccine. So the inclisiran Orion 1, they have studied the initial safety and other things. This particular Orion 3 is a long-term effect. That means even at 4 years, the benefits are seen. That means it's very encouraging. There may be a day when we take like influenza vaccine, every 6 months we take inclisiran injection. Then reduce it, just now the student was telling, this is about isotope and ethyl. It is a very purified form of omega-3. It's a positive trial actually. For the first time it's a positive trial, and it has reduced the total events as well as the first events. And in fact, Reddy labs and other 1 or 2 labs are coming up with this molecule. The only drawback with this molecule is you have to give 4 grams per day. 4 grams is 1 gram is this big capsule I was shown. So 2 tablets or 2 capsules twice a day is impossible to continue for long. Anyone will take it for a month or 2 months, but not for longer period. But it is going to become an important product which will come to you. Then with respect to hypertension, then there are so many ups and downs about renal denervation therapy. So what is the latest take on renal denervation therapy? Is it recommended or we have to wait or don't believe?
Sir, it is not recommended in guidelines, still not recommended in guidelines, but on clinical trials and investigation purposes.
Yeah, radiance is where actually they have studied the Paradise system. It's an ultrasonic system where very easily you can just put the balloon there and it takes some time to irradiate the things. And this is going to be very safe, and now FDA has approved it. So FDA approval is an important update on this renal denervation system. And so probably it will be coming for clinical use in wider way. Then this chart will tell you about important hypertension trials this year. One is Greek hypertension. It is about the aldosterone synthase inhibitor. It's a positive trial. Then there is a controversy about whether to give the antihypertensive drugs in the morning or night, which is good. This trial, that is time trial, has shown there is no difference. There is no difference. You can give either in the morning or night. Or if there are 2 molecules, you can give one in the morning, one in the night. Or if it is in the night shift, you can give in the morning. So you have a lot of flexibility. Doesn't matter. About renal denervation, I think the 3 years follow-up of the spiral hypertension therapy is very encouraging. It is still tending towards recommendation, though not strong recommendation. Then there is a comparison between hydrochlorothiazide and chlorothiazide. So pharma companies tend to tell this is better, that is better, but this particular trial has told that both are equal. So we can choose either way. Then CHAP trial is about what is the target for pregnancy-induced hypertension. Previously they were not treating unless it is crossing 150 or like that, but even 140 by 90 is also indication for managed. So the threshold has come down. Then is the heart failure trials. If you count, there are more than 50. The important ones are Valor HCM. Can anyone tell what is Valor HCM? Okay. What is the mechanism of action? I think we will tell you correctly. So the important update is that FDA has approved already in 2022. So now it can be used in select cases. In this particular trial, what they did, they have taken patients who are eligible and waiting for septal myeloma, and after giving that, 88% of them have come out of the list. So that means it is very good molecule. Then sodium heart failure trial, the controversy about whether we should be too aggressive in salt restriction. They compared two groups and they found that by doing too much aggressive salt reduction may not be of additional benefit. So that is the message from this. Deliver trial is again a landmark trial. It's a very important trial, not only for us, but for the pharma company. Why? Anyone can tell the rationale why it is so landmark trial? Yeah, it is SGLT2 inhibitors, not only for the
Preserved ejection fraction.
reduced ejection fraction, but for even mildly reduced ejection fraction as well as preserved ejection fraction. Now, in fact, this European Society guidelines has given it class 1 status. So it's a very important development. Then impulse trial is empagliflozin in acute heart failure. Whether we can use it in acute heart failure also is again positive trial. But recent another trial, dictate trial was negative trial. So it's not a robust finding. So anyone can tell what are the mechanisms of benefit by SGLT2 inhibitors. Look at this chart. There will be around 20 or more. Okay. It's a very beautiful chart, so I felt I should share it with you. So the benefits are to the heart, to the renal system, vasculature, body as a whole. Okay. If you take a photostat copy of this in your mind, and tell at least 10 of them. Then diamond trial, this talks about how to continue to use MRAs and RNA in spite of hyperkalemia. So if you use simultaneously patidomere, it's a good molecule to combine with RNA so that you don't have to stop RNA or reduce the dose. You can continue to use it in chronic heart failure. It's a positive trial. Edward trial is about adding estergolamide along with group diuretics and get better decongestion in heart failure. It's a positive trial. Then fluoritic trial, here they combined loop diuretics with hydrochlorothiazides in acute heart failure and got better decongestion. So a combination like oral hydrochlorothiazide you can add despite using intravenous furosemide. Then strong heart failure, this one is actually they have taken two groups. One is the high intensive care group and usual care group. In high intensive group, they do very rapid up-titration of the various molecules and follow up more closely, keep on encouraging the patients even in OPD visits, and they found that there is an important impact on the final outcome, that is called strong heart failure. Then coach trial is again somewhat similar, that is using a hospital-based strategy to rapidly follow up the patient and correct if there is any non-compliance, correct that. So just having good molecules is not enough. The strategy should develop where the molecules are actually taken by the patient in the right way. That is very important, especially for Indian subsets. This is very, very important. So many times we see SE inhibitors, we discharge with 5 milligram twice of Ravimpril. In the next visit he comes telling that my BP has become 90, so I stopped it or reduced it. My primary physician said so much dose is not necessary. These are common problems that we see in the COVID. So co-op trial is a 5-year results of Mitraclip in heart failure. This secondary MR is corrected by Mitraclip. It's a very positive trial. Safety and durability is proven. Then revived BCIS2 is somewhat similar to Stitch trial. Who can tell about Stitch trial? Very popular trial. Stitch trial. Okay, Stitch trial is about somebody has severe LV dysfunction and bypassable lesions. So So they are good for bypass, anatomy is good for bypass, and there is severe embolism. So that's a comparison between doing CAPG and optimal medical management. Whereas this revived PCI-2 trial is multi-vessel PCI versus optimal management. So what they found is, unlike stitch trial, here multi-vessel PCI has not given any higher benefit. So, but at the same time they comment that PCI did not harm also much. So it neither caused any extra benefit nor any harm. And the only thing they found is there is quality of life has improved at 6 months and 12 months, but that was not persistent at 24 months. So we don't know how to conclude the message from this. Then with atrial fibrillation again there are many trials. The one or two are very important. One is Invictus and Advent. And also there is a guideline by Heart Rhythm Society on cardiophysiological pacing for prevention of heart failure. That means conduction tissue pacing versus horizontal pacing or conventional CRT. Invictus is about use of NOACs, whether we can use NOACs in rheumatic heart disease with atrial fibrillation. Do you think we should use it? This Invictus trial is a trial which is negative trial, so we said not to do. What is RIVER trial? Somewhat related trial some 3 years back. RIVER trial is again about use of Rivaroxaban in bioprosthetic organs. And it was actually it was okay to use it. Like you don't have to. In this particular trial, Invictus trial, we found that it's better to use vitamin K antagonists rather than NOACs because the events are more with NOACs. Then Advent trial is again pulsed ablation, unlike the usual type of ablation for atrial fibrillation. It's a new thing, but it has not given very important positive results. So its non-outcome has not been well proven, and it is still to be observed whether it is better than the usual type of ablation for atrial fibrillation. Then with respect to valvular heart disease, the 3 important ones are: one is triluminate, evaluate low risk, and mini mitral trials. Triluminate is something like mitral clip done for the tricuspid regurgitation, and at 1 year it has shown that it's a good benefit to risk profile and significant improvement in the quality of life. Then evaluate low risk group. 3 years study has shown that the benefits were persistent, durable even at 3 years. Then mini mitral, there is a tendency for doing, and this is a comparison between sternotomy and mitral wall repair versus mini mitral. So mini mitral is very encouraging results with lesser morbidity. And from here onwards is rapid fire. I don't think I'll tell much about it, just show the slides, only 10 of them. SPOC 5 is about Cambrilla, transition from Ticagrelor to Cambrilla. Then we have got FDA approval for purchasing after Lodopo trial. Then very interesting is use of tergifatide for obesity. If you give it weekly once, obesity is well controlled. Well, there is a significant weight loss. And the same molecule has been tried in heart failure with obesity, and is again positive. Then icosapent I already talked about in reduced trial, that has been tried with respect to FFR and CT, and they found that the loss reduction is also demonstrated by users. So this molecule can be a good newer molecule for us as a secondary prevention. And dyslipidemia, there are now drugs for targeting triglycerides, LPA. LPA was never thought to be very important, but when we were students, Inas and Inas toured India, and everywhere he was giving speeches on use of nicotinic acid for LPA control. In those days, nobody was taking his idea with seriousness. Again, now the focus is on reduction of LPA for further risk reduction. I think just show the slide and close the session. Then there is a trial for with cardiomyocyte guided therapy. This is a heart failure trial. Can anyone tell about meteoric trial? What molecule was used? Galactic trial, anybody remembers? Galactic trial? That was a positive trial, but this meteoric trial is a negative trial with the same molecule. So it is. Okay. It is there, sir, but yeah. I think I close the session because there is no end to this long list. Best of luck to all of you.
On behalf of all of you, I thank you so much, sir. It's very difficult to even compile these trials. No one read about it. One small thing I'd like to thanks, sir, really for this book, which all of you got in your folders. Sir is now the editor-in-chief of IJCC, and the most heartening thing in the editorial that he wrote, which I had read initially, was the taking over the running horse, the running train. Sorry. It's given a lot of importance to DMT students who can actually publish in this. Sir has specifically made a mention of it, taking over from Michael Rousseau, whom we had earlier mentioned. I think all of you should take a page out of this, practically what I'm saying, and then try to publish this. Thank you so much for this. It's free online, it's been free online. On behalf of all of you, I thank sir. We'll now break for tea for 10 minutes if possible, 10 to 15 minutes, and then join back.